on uh, the lecture that the professor Dr. Dong Hoa Hao and Sang Q Shang um, and my own experience. Yeah, most of the experience is something that's difficulty and failure. So okay, and about my pre my presentation today is about some tip and trick, especially for some person with beginner um, and immediate EBE surgeon. Yes, I think so. Although uh, at this moment I still in the progress of learning um, lumbar EBE because I think I have experience about nearly 20 cases of EBE with TLIP and in a literature, as I know that. A surgeon need about nearly 30K continuous case for a short time to get familiar and to be expert in this technique. So uh, so and I can say that I still are the surgeon who are still learning. I'm not a very uh, expert and not a good surgeon in UBE yet. So today introduce some of my experience so far. Yeah. So I hope that you and many other surgeon uh, can can learn something from the presentation. You know that in the UBE, its theory is endoscopic in a water environment. So it is most important is that the UBE is just learn the technique from the arthroscopic endoscopy. It's not from the spine surgeon. It's from the other doctor arthroscopy. So uh, that's either um, the key that we apply in spine that we do the surgery in the water environment. So we have to uh, make the cavity for endoscopic. We always do the endo in the cavity. So the cavity, the important thing that we make the cavity for doing the endoscopic and doing the um, working portal. So making the cavity is very important for beginner um, to make the surgery successful. If if you do it wrong or you do it a little bit wrong, the case may be longer and it may be bleeding in the surgery, and maybe you got very disappointed about the surgery. So uh, when you do it in the good manner, it not only help you to uh, um, not waiting time, stop the bleeding, um, making their um, making their surgery operation feel more clearly and much easier. Uh, so here, the first tip I can tell you all is about the making cavity in the right way. So here we can see the anatomy of the spine here. Here is the muscle. Here the muscle of multifidus. It's the in heads from here to here. You can say that. Okay. We oftenly make a cavity between these muscle, and here you can see is the area of the lamina, and the most of the time we cutting this area of the lamina. So in this animation, you can see here this cavity, um, we're making this cavity is a triangle, making it bigger. You can uh, we uh, we can use a dissector, yeah, a big dissector to dissect a oblique uh, incision. Okay, to dissect these the to both muscle uh, and making a cavity between this muscle. Okay, you can see here. This is a cavity after dissecting. And here in the MRI, you can see the cavity from here to here. Okay, and so I once again I can say that making good cavity is helping you a lot in UBE. So after making cavity, in making cavity in as a beginner about more than 2 years ago, uh, I thought that we just do it dissecting a little bit, and then we use the RF coagulation to cut the muscle around, but it's not very true. We just dissecting the oblique incision around here, and we push the muscle away on the outside way, and we dissect uh, along with the bone of the lamina here, and we can see the lamina. Yeah, just like open surgery. Yeah, we can see this very clearly. If you do not see this anatomy clearly, maybe you do it wrong, but for the expert, I can say that they expose very little around here. But uh, then gradually the cavity is uh, bigger and bigger. So this interlaminar space, okay, this is the um, cavity, okay. Uh, and another important way of um, making flow. Yeah. Beside making cavity, we have to making sure that you can say that. So it's the water. Can you hear me? Anyone here?
Yes, it's okay.
Okay, okay. I'm sorry. I just see this. The Wi-Fi is some trouble. Okay. So here is the input of the water, and here the output, and we try to dissect that. When you finish dissect, you can still see the water coming out clearly and um, uh, stable. Yes, stable. And this way will help you to have a very clear view when doing endoscopic surgery. If the water flow is not stable, stuck sometime, it's very difficult. Surrounding tissue. Yeah. Okay. So here's some operation setting. Yeah, you can read the book to see how to set up to making the operation faster and convenient for you. Um, and the assistant here to help the to have the water in and out uh, in a very fast or in a very slow way. And Another tip is about doing the X-rays, the X-ray of the spine. You have you after you put the patient supine, you have to make the CM uh, as long as you you're making the right X-ray, the true AP. You can see here maybe as the L4, L5 surgery. You can see that the end plate at the end plate and the disc here and uh, the disc the end plate here is just in the same line alignment with the X-ray and here you can see the lamina and the spine posterior spine. Yeah, you can see it in the middle of the vertebra. So doing the good AP, you can after that you do the incision. Um, okay, you can also do the lateral X-ray to to uh, to see how your working portal and endoscopic portal look like. The triangle between the endoscopic and working portal. Most of the time, it's making a, a good triangle. It means that you easier. But sometimes uh, I have a sentence that uh, all for work. It means all of the surgery is for the uh, spine UBE. Most of the time, you do the surgery with one hand, and uh, you have to choose the working portal carefully. I can say that if you choose it wrong, it's gonna make the you mostly choose a wrong place for the incision for working portal. So in here, okay. So in here, we can make a example about the ischectomy surgery. And here in the left side, you can say that you can see that in the left side of surgery with a right hand surgeon, this is considered a standard for discectomy. So it's good for a beginner to learn the UBE. So if you are a beginner, you should do a left side discectomy first. It's gonna making you familiar, much familiar for the surgery and in
It's offline.
Hello, mọi người có nghe được không ạ? Cái
Nghe
laptop
rồi anh Bình ơi.
laptop của anh nó không bắt được wifi, thôi anh dùng cái điện thoại. Nhưng mà anh đang coi làm thế nào để share cái màn hình. À,
Dạ,
làm thế
anh
nào?
anh xem màn hình được rồi đó, em chuyển hot cho anh rồi đó.
Ừ, anh biết rồi. Nhưng mà tại vì cái giao diện nó nhìn không quen á, giao diện trên điện thoại không quen nên anh đang coi
Anh
làm
trình
thế
bày
nào.
cái slide xong chưa?
Chưa. À đây share screen này. Đây rồi. Cái máy tính lại vô được rồi. Bây giờ nó bị lỗi cái gì ấy? Mạng thì nó mất. Ok, hình như anh lại dùng được rồi đúng không?
Dạ rồi, anh xem màn hình lại được rồi đó anh Bình.
Alo, mọi người nghe được không ạ?
Nghe nghe nhưng mà chưa chưa thấy màn hình.
Dạ.
Dạ, anh share lại màn hình để anh Bình, anh tắt cái
Ok.
iPhone của anh Bình đi.
Anh chắc rồi, anh chắc rồi.
Dạ rồi, mọi người thấy rồi à?
Ok, cảm ơn. Okay. So it's a handwriting surgeon. Okay. So it's a this is
Dạ.
considered a
Anh mở
standard
cam của
surgery.
anh lên đi anh Bình.
Okay. 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 So it's a considered standard surgery for beginner to learn from the UBE surgery. So we can see here that um, uh, often we often choose in the book we often choose the incision with the horizontal true horizontal incision to make the endoscopic in here and working portal in here, and for incision to make a triangle with the center um, is the a posterior spine is in here. So with this incision, we can make the cutting of the lamina in this area. We can with the working portal. This working portal we can approach to on this area easily. Uh, and if you have a burr, it's easier. But if you don't have a burr with this type of incision, you can do the surgery easily with the Carrison. With Carrison, because you know that if you choose other incision, for example, in here, right here, you can hardly touch this points in here, so making the surgery difficult. And if you do the working borrow about right here, yeah, about right here, uh, you still able to cutting on the bone around here, but it's a little bit more difficult. And if you choose the working borrow in here, and so that the endoscopic portal need to be moved around here. Yeah, so when the angle of the endoscopic view, making the last angle, so making the view is not familiar with the normal spine surgery, the open surgery, who are familiar with the open surgery. And so this is going to be a standard surgery, standard incision, standard surgery. I like to use the oblique incision more than a horizontal incision, because it is the incision that's cutting in alignment with the muscle. So it's happy to cutting and dissecting the muscle easier. Dissecting the muscle easier. If you're cutting a skin with the horizontal incision, maybe you cutting too long, too deep, and it cutting down to the muscle. If you cutting like this, you do not harm to the muscle. Here, so this is making the borrow with the pole and muscle in here. So for the discectomy in the right side, with hand with left-handed surgeon, we have two options of skin incision. For me, if you have a burr, you can choose the principle. Yeah, my my principle is on for working portal. It means that the working portal need to approach to all the area that's necessary to task in the surgery. Here is the area that we need to task to work in here in a right discectomy case. So if you choose the incision in right here, it's not in here. It's in the uh, superior pedicle. It's gonna be too far. It's gonna be too far for a Carrison to reach in here, and you cannot choose the incision of working power near near this near this place. So this is the incision for working power in here. So we just um, endoscopic portal around here. You can see that it is the pedicle on the medial pedicle here. Yeah, you can make a horizontal or making a long incision right here. And the most important thing here to dissect the muscle and making the cavity around here. Okay, this is the option one for discectomy in the right side with a burr hole. Yeah. If you do not have a burr hole, so we have option two. So the option two, we move the working portal. We move the working portal a little bit lower, a little bit. Okay, just right to, we can say that we just put your working portal down. You're gonna touch the area of this of the lumbar disc here, and so this you can say that on the left side we choose this to be the center, but on the right side the center must be around here. Yes, but with this kind of choosing the working portal, we still able to with cutting the enough lamina and to explore the nerve root around here. Okay, so this is the option two for incision of the right side, and this is usually no need to use the burr. You just need the Carrison. So for the EBT lift, for EBT lift, we also have the left side and the right side. For example, for the left side in this picture, you can say that the surgery field, operation field is much larger than in the discectomy case. We have to put the case in. We have to cut on and on the disc here, prepare for the case and fusion around here. So it's on the left side is also a standard, standard and easier for the surgeon who are a beginner for TLIP. So this is the book on the book, incision on the book. You can see that it's about 3 centimeters apart. And this is the pedicle, upper pedicle and lower pedicle. So we just dissect this area. We dissect and cutting the bone about this area. And we make the a place for putting the case in this area. And here will be the dural sac around here. For me, I do not do much pulling tool because we don't have much. We don't have the good one, and most of the time I cutting outside, cutting the disc outside, and then I put the case in this area. So this is the incision for left side standard. For this play, you can both do two things. You can dissect, you can cutting all the work here in endoscopic, and the secondly, you can making the screw. You can put the screw on the spine on the vertebral in a same incision. So this is the option one. You mean that the UBE portal or working portal is the same with the screw incision. Yeah, it's part of the time it's making me harder to do this in the same time. And with this incision, most of the time I have to use the straight case. We cannot use the curved case and a big case in this way of incision. So this is for left side, and this is the option one for left side. Okay, so for the left side TLIP, we have the option two. Option two means that the incision for endoscopic is different from the incision for the screw. You can see that this is the incision for the endoscopic portal. Endoscopic portal is a little bit near the midline. Yeah, you can see that. And this is incision for the working portal. Okay, it's just like a discectomy, Okay, and then you putting the case with this incision. Okay, so you finish the endoscopic stage, and then after that you move to the screw with two incision. Yeah, on about 1 centimeter, 1 to 1.5 centimeter apart, lateral to the pedicle. Yeah, so you have 4 incision, but this incision is small. Yeah, it's small. This is bigger. And this incision is not according to my experience, is not making the patient much pain after the surgery for the incision, because we do not dissect much in here, so making it do not cause much pain in here. Okay. Okay, this is for the left side, and the option two for incision. So this is the right side. So for the right side, we also have option one and option two. Option one would be it will be portal is the same with the screw incision. You can say that on the right side, you cannot making the incision right here and right here. It's a little bit difficult because making the incision right here and right here to do this two purpose. First, making the screw and doing the endoscopic uh, stage. Endoscopic stage is difficult. Yeah, I can say that it's difficult, and you can say that if you're putting the incision right here, if you can decompress, you can cutting the case, but when you putting the case, it's difficult because it's not in the in the same alignment with the dish, and it's turned out that uh, you can making the case in not in a good position. Maybe it making the case on the vertebra right here. Okay. So for this case, once again, we can only use the straight case. And so to do the UV poro is the same with the screw incision. We have two options. Yeah, the first option that the working poro must be here. Yeah, must be here. And then this incision is for the lower screw, and we have to make another incision right here for another screw. And here is the endoscopic portal incision for the endoscopic portal. So we have three incisions. This one is for screw, and this one is for screw and for working portal, and this one is for endoscopic portal. Okay. Then an option 1B would be like this. Be like this. We move this incision from here down near here, near the end plate here, and lower to the endoscopic here. Yeah, for this incision, yeah, we can still do the surgery, but you have to be careful to um to putting the case in the alignment with the dish here. So in this option, you still use the straight case. Sometimes this incision is easy. Sometimes it's easy. And an option two for on the right side is me. Yeah, we do the UV portal. It's different from the screw portal around here. This is a screw portal. Yeah, right in the outside of the pedicle here. And this is the UV portal. This portal is for endoscopic portal in here for the working portal. Yes. So this is the option two. And for this way, it's the surgeon is more easier to do on the stuff on the working on the endoscopic surgery. If you do the option A, the option A like this, all the thing have to do in the same incision. It's really more difficult, more difficult. Okay, and once again, and if you do the incision right here, you can put the curved case, and I think it's a better for the patient for fusion. But if you have a a case a big case you also can do this incision. But in our hospital, we do not have a big case for this situation. We only have a PLIP case, straight case for PLIP. So it's not much good for the patient. So with 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 this option, you are more familiar with the surgery, and in the same time you are using the curve case, the bigger case is a little bit better for the patient. But in contrast, you have to do 4 incisions in the same time. But it's not very long. Yeah, you can say that. You can choose whatever. So another tip is about the bone work. So it's a familiar. So that the bone work here, you can see the lamina, interlaminar space, the infant Mandibulum, okay, flavum ligament in here. You're cutting this lamina until you see the edge of the flavum, and here you can see that the V shape, the V shape of the flavum. It means that you are gonna touch another part of the flavum. When you touch another part of the flavum, you can cutting a little bit of the spine of the spinous process in here. Here you can see that the archer is cutting the base of the spinous process in here to decompress to the contralateral side. For this picture, you can see that they use the shield to cutting the IAP in here. Okay. So after doing the bone work, you have to cutting the ligament flavum in here. This is the epilateral side. Okay, after you can cutting layer and layer, superficial layer and deeper layer of the flavum. Okay, and then you're cutting a little bit more of the inferior lamina in here, and then you're cutting on the lamina to see this area. You can see that it's a dura sac, and here the pedicle, and here is the dish. It's a dish. You can open this area about 1 centimeter, yeah, to put in the case more easier, because if you do not have a pull tool to pull this Durasec to lateral, you're gonna have a very difficulty putting the case. So for me, I set very lateral, and so that I can do not use the pulling tool here. And for the lateral, contralateral side, the compression, my tip is I gonna cut. I gonna cutting the flavum contralateral side first, and then we use the kerosene to cut this one, the IAP, because the flavum is some case very big, and it's will stuck to the view of the endoscopic view, and you cannot see anything. Or maybe you have to use a burr to cutting very very much of the bone here at the base, but you do not want to cut much at the base. You just cutting the flavum, but you have to be careful with the complication of cutting or tearing the dural shape. So this is the amplet preparation. This is the area that I told before. Yeah, it's about 1 centimeter from dural shape to outside. Yeah, you're gonna easier to put in the case. This is where they use the pulling tool. The pulling tool is a design for the UBE only. Yeah. Right now we do not have this device, so we do not use the pulling tool at all. So here the X-ray. Yeah. Okay. So this after that we check the nerve root and we finish the case. We're doing the screw. So this is the end of my my presentation, and this is more the term is my my that's come out from my mistake. I learned from the mistake of my own. Okay. Thank you very much. Thank you all very much for listening.
Okay, well, I can.
Do you have any question or something?
I think it's a nice presentation for the basic concept of the UBE. And because I want to share the uniportal full endoscope surgery in my presentation. But before that, I can show a case of the UBE case of my early case in the UBE. And I can show the video to help other doctors know about what you just share our concept.
Okay. Thank you.
Let me wait a minute.
Yeah, so now you can share your screen. Thank you.
Okay. Okay, can you see the video?
Yeah, we can see the screen clearly. Thank you.
Yes. So this is the first image. I already clean up the room of the muscle at separate from the bone. This is the lamina edge of the upper vertebra, and I will use the coagulation to separate the Flavin ligament. And this is a herniation disc case, so I just use the burr to have some partial laminectomy. And this is the shaver in the arthroscope, and I use in the UB surgery. This is the protector. It's more safer. I can push the Flavin ligament away. And after that, we can have the Flavin ligament, have the window. And just like our microscope technique, we can split the Flavin ligament and remove the Flavin ligament. Of course, we must to decompress the next level of the lamina, and we can see the nerve root here, and I will decompress the nerve root before I check the disc. So when we see the nerve root here, and we can use a protector to push away the disc and push away the nerve root and do the discectomy. Yes, this is the disc, and we can do the discectomy, just like we do in the microscope. But we only have one hand, so this protector, we need our assistant to hold the protector, and we can do the discectomy. And after that, we can complete the discectomy and close the wound. So this is I think the UBE is more familiar to our open surgery, the anatomy way. We can the OP field and what we see is just like the microscope surgery. So I think it's more easier to the beginner to do the endoscope surgery. So, and I want to share my full endoscope surgery. It's my time to presentation or other doctor want to see the to ask the question about the UBE? So I will present
So
my.
I think yes, it's more useful for us if you share your lecture. So please start.
Okay.
Okay. Yeah.
Okay. I want to share my experience of the endoscopic spine surgery. Before that, I will have a brief. I just found this picture when your presentation, and I went to Dr. Sang's hospital many years ago, maybe 7 years ago, and this is my teacher, Gang Chui, is the president of the endoscopic and minimally invasive surgery in Korea, and this is Dr. Yang, and I have some work a partnership with him. Maybe 5 or 4 years ago, I went to mainland China, and he had a company to do the spine surgery at Chinese hospital, and I have the chance to go to there for a part-time work with him. And we all know that our spine surgeon deals with many kind of disease and problems, but the lumbar disc herniation disc problem is many common disease, and we can do the open surgery, microsurgery, MED, or endoscopic surgery. And we have the history of the endoscopic spine surgery, but I will not talk a lot about this. You can see the previous technique of many doctors before. And the most important is the doctor cabins. We can see the cabins triangle. This is a very important anatomy structure for the transforamen spine surgery, endoscopic spine surgery, because it's a safe room. It's a safe room for the scope going to the foramen. This is the existing nerve root, and the transverting root is at the middle side, and this is the pedicle and the SAP, superior articular process. And we put the scope here. It's very safe to not to interrupt the nerve root, and we can do the decompression of the disc remove. So when the technology had developed the full endoscope instrument, we have the working channel and the scope in one instrument. We can really do the full endoscope spine surgery. So many companies do make up the spine instrument, endoscope spine instrument, but they are all not and that they are all the same in the scope. So we can see the development of this endoscopic spine surgery. Now, I will present the different kind of the transformation procedure. We can go inside the disc, or the disc is just like iceberg. We have the large portion of the inside disc, and we have the herniation portion of the disc. We can go outside. Outside is just from the foramen and go into to approach the herniated disc, or we can go inside out. Inside out is we just put the scope into the disc, and after decompression we can go out and to do the herniation disc, or we can have the half. Half is put a scope at the margin of the disc and the herniation way. This is outside. Inside out. Inside out is put the scope into the disc, and outside in is put at the neural foramen and go into the foramen. And when the herniation disc is at the different location, we have the different access to the disc, just outside in or transforamen to do the more centrally, or we can do extralateral to deal with the extraforamen disc. I will show the cases to you. And when the rupture disc has some migration, we have the countdown migration is most common, and we can see if the migration is go upward migration. When the zone 2 and the zone 3 is more easier, but when the rupture disc at the zone 1 is beneath the upper pedicle, and it's more difficult. We have to because the essential is here, is nerve root, existing nerve root is here, and we have to have some approach to not to injure the essential root. So zone 1 is more difficult, and zone 4 is downward to near the next level. So we have to maybe do more the bony work at the pedicle or the lower body. So this is the AO spine category for the endoscope spine surgery. The UB is defined as the endoscopy assisted surgery. It's not, and the full endoscope is the one portal spine surgery, endoscope spine surgery, one portal. The working channel and the scope is in one sheath, one portal. And the others are defined as the endoscope assist surgery, like the transforamen, like fusion or UBE fusion, or the MED, MEL, or UBE is the more like endoscope assisted spine surgery. So the full endoscope spine surgery, we can do the discectomy, we can do the foraminotomy, we can do the decompression, or bilateral ULBD, unilateral or bilateral the decompression. And we can do the C-spine and T-spine. And in my opinion, I think the best procedure, best surgery is depend on the surgeon. If you have familiar to microsurgery and you can do microsurgery very well and resolve and solve the question, the problem of the patient, it's a good surgery. And if you are familiar to the UBE, you can do very good UBE surgery. And I prefer to left the endoscope surgery to the disc. So I did not do the C spine or T spine because I think I can use microscope to deal with the problem more comfortable and more safer and safer. So I use the microscope to deal with the C spine and T spine. And I know many doctors and many surgeons use the endoscope, full endoscope or UBE to deal with the C spine or T spine. I think it's very, very good, but I'm not to the C spine and T spine surgery. So I left the full endoscope surgery to the disc, to the discectomy mostly. So I have some procedures to present to you, and this is my do the transforamen or interlaminar procedure. I will check the CM to make sure the true AP view of the disc level, and I line up the midline, and I calculate what will where I will put my scope in, and I will use the punch needle to assess the cabin's triangle, and I put my dilator in, and this is the sheath, different sheath. This is a shorter sheath for the interlaminar. Sorry, and this is the transforamen. Sorry, this is the transforamen sheath, and this is the sheath for the foraminoplasty. I use the profile to do the foraminoplasty, and some doctor use this kind of foraminoplasty, but I did not use this instrument. And there are different instruments for the spine surgery, endoscopic surgery. This is the cutter, and this is the forceps and Curison. So I put the scope in, and we can do many. We can even do the contralateral side. This is the interlaminar interlaminar the endoscope spine surgery. We put the L5S1 is a larger interlaminar space, and we can directly put the sheath at this space. So I will share some cases, 3 cases of different kinds of disc. This is a 52-year-old woman, lady. She has the right side sciatic, and we can see the L5S1 disc. This is a perfect case for the beginner because L5S1 is more wider interlaminar space, and we can directly put the scope at this position, and the anatomy is more familiar like our open surgery. Also, I use the interlaminar intersural lumbar discectomy. This is my video. We can see this is the caudal side and the cranial side, and this is the foramen ligament. We can use the cutter to let the foramen ligament thinner, and when we have broke the foramen ligament, the water flow will go into the epidural space. We can see the epidural field here, and we can use the cut to expand the foramen ligament. So when I expand the foramen ligament, we can see the epidural fat. Here is the epidural fat. I will remove the epidural fat to see the dura more clearly. And I will see this is the S1 root. This is S1 root. And if we want to do the discectomy, we have to see the shoulder of the nerve root is more safer than the axilla. I think never to do the discectomy from the axilla. It's dangerous to injure the nerve root, and we can put our probe at the epidural space and push the nerve root immediately. And in some cases, if the disc bulging is a very large bulging, this is tight to compress the nerve root. And so when we do this procedure, we have to very careful. And after I check the probe is not compress the nerve root, I can push the nerve root more immediately. Then the sheath will go into and rotate, and we can protect our nerve root immediately. So this is the bulging disc. And in this procedure, we have to be very careful because if the sheath is compressed the nerve root, it may injure the nerve root. So I will check the nerve root here. This is the nerve root, not compressed, and the caudal side, and this is nerve root. So I have checked the nerve root is not compressed by my sheath, so I can do the discectomy. And this is epidural vessel, and then after then I will put annulotomy, and I can do the discectomy. So after we remove the disc, bulging disc, we can rotate back the nerve to see the nerve. And after the discectomy, the nerve roots return to the natural position, and we can use the water pressure to check it's not compressed anymore. So after that, I will check again to find out if anything I left, any disc fragment I left, and I will also check the axilla region. Is there any disc fragment here? But this cannot do before you decompress because it's very dangerous to to interrupt the ACL region. So this is the interlaminar approach for the L5S1 discectomy. Another case is a 50-year-old man. We have a sudden onset severe left side sciatica. We can see a rupture disc here at the L4-5 left side, and it's caudal migration to the rung 3, not even close to the rung 4, but not to the rung 4, just at the rung 3. So I use the transformer approach. I put my sheets at the cabin angle, and this is my video. Because this case at the caudal migration, the scope view is this is the SAP, and this is the disc, and the transversing root is here, and eccentric root is here at the left side, and I need to remove the SAP, but I usually to do the discectomy first, because if the margin disc is compress the nerve root tightly, the patient is very painful. Because the transformer surgery, I will use maybe the local anesthesia or the IV general anesthesia. The patient is awake. It's awake surgery. So I usually to do the discectomy first. And you can see the disc have some blue color because I use the dye. I use the pattern blue dye to do the discogram before my surgery. I can see the disc very clearly. Now I use the high-speed burr to remove the SAP. I want to go more caudally to reach the rupture disc, and I need to remove the SAP. And this is many kind of way to remove SAP, but I think the high-speed burr is more is safe for the remove. And I can, after the SAP remove, I can see the tip of the rupture disc, and I can use the forceps to remove the disc piece by piece, and you can see the blue color here is the dye I just before the discectomy. So it's a very large rupture disc in this patient, and we need to very carefully, because I want to remove all in one piece, because if the rupture disc is separate, and maybe we cannot remove totally. So we have to have patience to remove the rupture disc very careful and then gentle. So after remove all of the, it's a very large rupture disc in this patient, so it's very painful in this patient. So after remove the disc, we can see the epidural space just downward, and we can see this is epidural space, and this is the transversing root. And if we totally decompress the nerve root, you can see many small bleeder begin to bleed, and it may be in many cases, if we have a large herniation disc or rupture disc, when we remove the disc, and the epidural space they begin to bleed. It means we have completed the decompression. And I will check the eccentric root here. This is the eccentric root here. Eccentric root here, and this is complete the surgery operation. And in the third case, is a 38-year young man have left side sciatica. We can see the MR image. This is a extraforamen disc. We know if we do the open surgery or the microsurgery for the extraforamen surgery, I usually to use the paramedian incision, and I will find the transverse process and the lateral side of the facet joint, and to find out the disc and the extraforamen disc. But in the open surgery or the microsurgery, there is many soft tissue like muscle, like fat, or some fascia here. It's not very clear OP field to find out the disc. In addition, we also worry about the nerve root. Why we don't want to injure the nerve root or the dorsal ganglion. So it is a perfect case for the endoscopic spine surgery to deal with the atrial foramen. Because we can just put the scope to the atrial foramen disc and remove the disc, and we don't need to even go into the foramen. So this is my discogram. Before my surgery, I used to do the discogram with and dye, and we can see the atrial foramen disc is here. So I just put my sheath, my endoscope to the atrial foramen, not go into the foramen. So when I scope put into the sheath, we can see the rupture disc just in front of me, and it's very comfortable for me to remove that. But because we all know that the bony structure for the spine endoscopic spine surgery is very important, because sometimes we cannot to know where is the nerve or the vessel or the muscle fiber in our scope. So we have to find out the bony structure. But in the atrial foramen, we don't know. We don't know where the bone. We don't see the bone structure. So in this case, the patient is awake, so I can know the patient's reaction. Just like this, we have a bend at the disc. I don't know is the nerve root or the muscle fiber or vessel, and I will touch this band and see the patient reaction. If he have pain, I will worry about is the nerve root, but in this case, it's just a muscle fiber. So I can just cut this muscle fiber off. Oh, cut off is not the nerve root. Oh, so we can see how atrial foramen disc fragment in front of me. So I can remove all of this rupture disc. Oh, this patient is a very tall and strong young man, and this rupture disc let him lie down on the bed and did not want to move because it's very painful. After remove the atrial foramen, I can see the blue dye I just do before like surgery, and I can I will know my direction. This is the disc direction. So I think the discogram with the dye is very is made my surgery more safe. So I can remove the rupture disc totally. After that, I won't go into the foramen because I have complete my purpose. So the surgery, the operation is done, and the patient can leave the bed after the surgery. So this is my 3 cases and my presentation. This is my hospital in Kaohsiung City, and my name is Yuren Wu, and thank you very much. Well, is any question we can discuss?
So thank you very much for your interesting presentation. And so maybe there's a lot of questions for you.
The first question is uniportal. You until you uniportal endoscopy.
Pardon?
The video you saw us seem that you use uniportal. Why don't you use biportal?
How many years? How many years? Do you ask me how many years?
For you. So right now at our apartment we use biportal endoscopic surgery. I think it's much easier for us to decompress and to deal with the problem when we do surgery. But the video you saw, it seems that you use just one portal spine surgery.
Yes, the uniportal. Yeah, one portal. But I can do the two portal spine surgery, but because I think microscope spine surgery is a very good spine procedure for our neurosurgeon to do the spine problem like disc or decompression. So I think the two portal spine surgery. I will leave the two portal spine surgery to maybe the decompression because it has advantage to do the contralateral decompression in the two portal spine surgery. It's more it's faster because the one portal spine surgery have to take more time to deal with the bony part. If you use the one portal to do the spinal stenosis decompression, we maybe take maybe 2 hours to do the bone part to the contralateral. But in the two portal spine two portal UBE, we can do the bilateral decompression in maybe 1.5 hours to complete the decompression because we can use the Carrison punch. We can use a larger spine, larger high speed bird. We can do the bony parts more easier. So I use the one portal endoscope. Just I prefer to use the one portal to just do the disc, just do the herniation disc. Yes, yeah. Because I can do this, but I don't like I don't like to use the endoscope to do all the surgery. I know there's many surgeons in Taiwan. In Taiwan, we have the Society of the Endoscope Spine Surgery, and maybe there are 300 surgeons in this society. We discussed the endoscope spine surgery every month. We use the CME discussion online, and we have the meetings to discuss all kind of endoscope spine surgery. Many surgeons do the every case in endoscope, but I think it's more difficult in some stenosis or decompression. Use the endoscope. We can do the microscope very easier and simple, and not take many time. So in my experience, I contacted the endoscope specialist more than 7 years, but I just use the endoscope to deal with the herniation disc right now because I think I can do other complicated or difficult case in microscope. Yes. But if we want to develop the endoscope spine surgery, I think the UBE is more easier to do from the open surgery to endoscope surgery because the anatomy is more familiar to the open surgery. The uniportal, one portal, especially the transformant approach is very different from the open surgery. It need a learning curve, maybe 20 or 30 cases to do the transformant well. Yes, it's my experience.
Yes, it seems that you perform a lot of endoscopic spine surgery, but it seems that you just focus on the lumbar spine. So I think you get familiar with the way you decompress the disc innervation. So why don't you recommend for us or for you to use the endoscope for the C spine or T spine?
Uh, if you want to do the C spine or T spine, because uh the T spine or C spine is the spinal cord, and the endoscope surgery, even the one portal or two portal, we have the water pressure. We have the water pressure, and when our water pressure or our instrument is it's very easy to injure the spinal cord. So if we want to do the C spine or T spine, you you need to be very familiar to this procedure from lumbar spine. So maybe we can do the lumbar spine surgery for a period of time for maybe 30, 50 cases. And we are very familiar to the procedure and we can challenge the T spine or C spine. It's more safe.
Mhm. So let's go to the case, the second case and the third case you just presented us. You remember the reason of the case two, the case two you present us. Could you please to move back the image of the second, I mean the case two you just present us the lumbar disc animation, and you choose the foraminal approach. I
Um,
yeah I think you can choose another way.
yes,
Yeah.
because I know I can do that. So it's more difficult for the beginner because the downward migration, sometimes we cannot uh, especially for the beginner, or we cannot uh, totally remove the downward migration disk. It's a risk. It's a risk because if we do the interlamina or the UV or the microscope, we can do more bone work at the lower lamina, and we can find out the downward migration disk. It's an easy case for it's a simple case for the microscope surgery to do the downward migration. But I when I see this case, it's a fresh case. It's not the patient had the symptom for just about 2 weeks, so I know the disc fragment is fresh. When the disc fragment is fresh, it had the chance to be one piece of the disc fragment. So after discuss with the patient, and I told him about the risk that maybe I cannot remove over the disc. I will tell him, but I think I can do that. So I just choose the transformation approach. Uh, of all these endoscopic procedure, I like the transformation approach most because I think it's a very powerful tool because the patient is awake. Or it know what I'm doing, and I can know the patient's feedback, and I will do this maybe 1 hour or 19 minutes, and when I remove the fragment, it it just cure all of his problem. So in this case, because in this case, just yes, it's not an easy case for the endoscopic surgery from the transformer, but I think I can do it, so I choose the transformer. Yes.
And so why did you choose acquired surgery? So why don't you choose general anesthesia for this patient?
Um, if um there are two kind of if you want to use the general anesthesia, the patient is more comfortable because when you have some interrupt of the nerve root, the patient may be pain and may be nervous. So, but if the patient is awake, if you don't, you did not show what is the structure is, because you just like you don't know what is the nerve root, you can touch the structure gently. And if the patient have the sciatica, we can know that is nerve root. So for the beginner, it's a trick. For the beginner, you want the patient to sleep because you are nervous. The patient are nervous. When the patient is nervous, you are more nervous. So for the beginner, you want the patient to sleep. But for the beginner, if the patient is asleep, you may injure the nerve root and you don't know. So for my first 10 case, I use the local anesthesia, not the general anesthesia. And I ask my other surgeon, they have the experienced surgeon for me to look at me to do the surgery. So I can make sure I will not injure the nerve root. And when I have more familiar with this surgery, I will ask the patient if he want to sleep or not to sleep. I will talk with my patient. But many patients want to sleep. They don't want to experience the surgery. But but if I want, like this case, I want to let him not to sleep. So I told him I have do this in local anesthesia. It's more safe for him. So the patient is not under the general anesthesia. For me, I can do both. The general anesthesia or local anesthesia is okay. But for the beginner, I suggest local anesthesia because you don't know where you don't know where you will injure the nerve root, but the surgeon will be more nervous because the patient is because you have take time and you have take a lot of time to do the surgery. I think the patient maybe 2 hours is most the patient can tolerate to the surgery. More than 2 hours, maybe the patient want to go to a pee or he have the soreness of his spine, and maybe he will move just then. And then when you cannot complete the surgery, the surgeon will be more nervous. So I think it's better way to ask the more experienced doctor to help and to make the surgery not take too many and take too much time. Yes.
But as far as I know, we still have another method to make sure that the anatomy or the structure you handle with you can use interoperating neurophysiology monitor.
Yeah.
So in your apartment, do you use this when you do spine surgery?
We have the equipment. We have equipment, but I usually not use the monitor. Yes,
Yeah.
because maybe when we set in the monitor, I already completed the surgery. Yes.
Okay, so it's
But I think it's a good way to monitor, use the intraoperation monitor.
yeah. Yeah. So I like to ask my colleagues, Dr. Ben. Dr. Ben, do you have any question? Dr. Ben is the neurosurgeon that just presented with us his expertise. And now I like to ask him if he has any question for you. Dr. Ben, I see you still here. Do you have any question? So nowadays, endoscopic spine surgery is developing so much. Yeah.
Hello. I'm sorry. I have some a phone call. So, can you repeat the question? I uh, I do not have any idea. I I have do the um unipolar surgery, a full endoscopic surgery for uh um uh about 4 years ago, but recently the full endoscopic surgery we do a very few, very little, and I, I, uh, I have some experience, a little experience about the case of discectomy with full endoscopic of surgery. So I can see your presentation is very helpful, and I think more idea. I don't think I have any other idea. Yes, thank you for your presentation, Dr. Yulun. Who? Okay. Em hết ý kiến rồi Tình ơi.
So, okay, thank you very much for joining us today, and we hope to see you in the future. And I hope you develop your skill in endoscopy spine surgery as much as possible. So, bye bye. See you again. Bye bye.
Okay, see you.
See you. Bye bye.
Yeah, see you
Yeah.
next time.
Thank you.
Thank you.